All right, well, good afternoon, everyone. It looks like everyone's not too many people joining anymore, so we'll go ahead and get started. There is a little bit more to cover with transfemoral prosthetic design as opposed to transtibial. So a lot of the initial content is very similar to what we spoke on last time, so we'll kind of breeze through that. But review it again for anyone that was not able to make the first presentation. So we're hoping to identify some initial demographic information, amputation levels, causes, patient population data, things like that. So we'll kind of take a quick look at that. We'll review the anatomy of the transfemoral residual limb, some general landmarks and things that we typically use and are helpful when discussing a transfemoral limb. Understand and kind of review the general prosthetic timeline again, and again, go over those mobility levels and how that influences our options and choices as clinicians. And then also talk about basic design principles when we're looking to design transfemoral prosthesis. And then talk about how we're going to match those to our functional level. So for the demographics, again, we've got estimated 2 million. This was back in 2018, and that number is expected to continue growing. So I'm sure it's larger by now, but estimated 2 million persons living with amputation in the US. 900,000 of those with major amputations. There's 185,000 amputations performed every year. And by 2050, that number is expected to jump to 3.6 million persons with amputation by that time. So as we start looking at the demographics, the largest cause of amputation is dysvascular related, and 2/3 of that group also have diabetes as a comorbidity. So kind of goes against some of the common misconceptions. A lot of times, one of the first things people ask me is, "Oh, I'm assuming you see a lot of people that have been in accidents or veterans returning from war." Well, that's certainly a portion of what we see, but dysvascular related causes are higher than trauma. That does come in second at 45, and then 1 to 2% for cancer. Um, 65% of amputees are male and 35% are female. That can potentially be associated with some more risky behavior in that traumatic group. Males tend to do things that are a little bit more risky than females, and tend to have more traumatic amputations. Under 65 is around 58% of all amputees, and then there's about 42% over 65. And again, that number is expected to grow with the aging population. So when we look at race, 58% are white or Caucasian, and then non-white at 42%. When we look at lower extremity amputation specifically, 65% of all amputations and 94% of all major amputations. And again, dysvascular disease causes 78% of those lower extremity amputations, which is quite high, and then 20% for trauma, and 1 to 2 for cancer. All right, again, so we're going to go over this prosthetic terminology again. Again, the prosthesis is a device or external or implanted that substitutes or supplements a missing or defective part of the body. A prosthesis is a noun. It describes a thing. A common mistake that people will make is calling the prosthesis a prosthetic. That is incorrect. A prosthetic is an adjective. You could say a prosthetic device, a prosthetic knee, a prosthetic foot, or prosthetic limb, but not a prosthetic. That doesn't have you need a noun to go with that. So prosthetic is of or relating to an artificial body part or prosthesis. Prosthetics is the field of study and of making artificial limbs. And a prosthetist is a specialist, the professional in that field that makes and fits the limbs. Generally speaking, appropriate terminology to use when referencing people with amputations is person of amputation. Instead of calling the residual limb a stump, call it a residual limb or residuum. You will occasionally hear patients calling their limbs stumps, but professionally we try to avoid that. All right, now let's start getting into a little bit more of the nitty-gritty here with transfemoral in particular. So reviewing anatomy, some of the major anatomy that we focus on is in relation to the pelvis, particularly the lower end of the pelvis, as well as the femur. So we oftentimes will reference the greater trochanter, distal femur, ischial tuberosity, ramus, and the ASIS. Those are some of the major areas that we focus on, particularly when trying to fit a prosthesis. And those are also kind of some common areas that can have discomfort or need particular care when fabricating a device, particularly the ischial tuberosity and ramus. And we'll get into why those are really, really important landmarks here in just a couple of minutes. So when we talk about amputation of transfemoral above the knee, right, we're talking about as you lose length, you tend to lose adductor strength. Some interesting things to note, right? Normal femur adduction is around 7 to 10 degrees. The adductor magnus, which is the largest adductor muscle, has 3 to 4 times larger cross section and volume than the adductor brevis and longus spine. And that inserts quite distally onto the femur, right? So as you start amputating at the femoral level, as you move proximally, you're losing that attachment point. You're also changing you're changing the adductor insertion point. So you're changing the lever arm and the strength, right? You're shortening the muscles. And in some cases, as you move more proximally, more and more of that musculature is amputated. So at 1/3 femur length, or excuse me, not at 1/3 length, amputating 1/3 of the femur length has a 70% reduction in adduction strength without a proper myodesis. And I guess now's a good time to jump down and kind of note the difference between myodesis and myoplasty. Myodesis is anchoring of the muscle to the periosteum and bone itself, right? So that muscle is anchored into the bone. When the muscle fires, it's acting on the bone directly. Myoplasty is when muscle gets sutured to muscle. This can actually create quite a few problems for us, prosthetically speaking, because if it's not attached to the bone, it's able to move around and it ends up pulling the tissue. This can cause many, many problems and many difficulties when fitting a residual limb, because then you have this moving target. The shape of the limb changes between firing of a muscle and relaxing. So it's, if those adductors are not properly secured, or if they come loose, that really generates a lot of problems for us and a large reduction in adduction strength. And as you continue to move up the femur in amputation, as you get a shorter and shorter residual limb, you're going to have weaker adduction strength. And kind of what, let a couple people in here. What can also kind of exacerbate this adduction problem is that many times the abductors, the abductors, are still intact. They're usually not affected in the case of a standard amputation. So, right, you have your main abductor, your glute med, up there at the trochanter, still able to fire away. So it's, as you get to really short residual limbs, it's not terribly uncommon to have more and more problems maintaining that abducted femur. And it's not even that uncommon as you move shorter to start seeing more abduction contractures, because there's just not enough strength to pull the residual limb back into that normal alignment. And again, whenever we're fabricating a prosthesis, we're trying to, the whole battle in the transfemoral game is to try to present as much of a natural alignment as possible. We'll get into that specifics of how we do that a little bit later. So again, reviewing the timeline for fitting of a prosthesis. IPOPs are not nearly as common for the transfemoral level. They're quite a bit more complicated. Typically what I've seen a little bit more of is kind of an early fitting and post-operative type device where you're simply trying to protect the residual limb. And that's really the goal at this stage, is to protect the residual limb, help control swelling, and help to make sure that everything's getting stabilized. Typically with these devices, they're not really meant for walking and even very much weight bearing at all. That's very much regulated. Most of the time it's only toe touch, if any. And again, a lot of times these are not used, especially in the weight bearing, distal attachment. They're more typically used as residual limb protectors because we want to make sure we're giving that limb time to heal. More common during this kind of early phase, since these two types of devices are not fit very often. More commonly, what we'll see is wrapping of the residual limb and shrinker use, which we'll get into here in a second as well. But the goals during this initial time of healing, during the first couple of weeks to couple of months, we want to protect the residual limb. We want to make sure that the sutures are the wound is healing nicely. That we're not developing any contractures, where the swelling is being controlled and limited, and we want that residual limb to heal and be prepared to accept a residual or a prosthesis. So shrinkers in the transfemoral level can vary a little bit. The ones I've chose to picture here are the ones that we typically fit, but there is certainly some variation in shrinker design. However, the shrinker function, the goals are to provide that compression to the residual limb to help reduce the edema that's present after the amputation. So typically shrinkers are fit after suture removal. Every now and then we'll have a physician that wants to go ahead and get a shrinker started before the sutures are removed. However, in that case, you want to make sure that the distal end is protected, a light dressing over the sutures or any wounds there. You definitely don't want the shrinker going right against that. But that's certainly kind of that's done less frequently. More often than not, we're fitting right after suture removal. Typically, we like patients to receive 2 shrinkers, and they're worn 23 hours a day. And this is quite important that patients are wearing the shrinkers consistently. It needs to be under that constant compression, so that whenever we go to fit the initial preparatory prosthesis, that there is not as much of a volume change initially. And we like to have patients wear the shrinkers for around 2 weeks before they come in for their casting. So for donning a transfemoral shrinker, again, we're going to cover any wounds or sutures with thin non-stick dressing. Again, you'll kind of roll up the shrinker like you're putting on a sock and pull it up over the residual limb. It's really important that the the proximal medial end of the shrinker is all the way up into the groin. That needs to be as high as possible. At that time, you'll attach the waist belt. That's just a simple Velcro, and that kind of holds the shrinker in place and helps keep it from falling down. Most of the shrinkers will then have a little ring that you can see there at the bottom of the residual limb there, and you push that ring up until it kind of touches the end of the residual limb, and then you reflect the remaining part of the shrinker there that's hanging that you can see hanging down in the picture. That gets reflected and then pulled up. And again, it's really important to make sure that it's smooth, limit the wrinkles. You're going to get some of the wrinkles at the distal end. That's okay, just smooth them out as much as possible. You certainly don't want to end up with any proximal wrinkles, especially wrinkles that go around the circumference of the residual limb, as that ends up creating a choke point on the limb itself. And then the shrinker is no longer really effective because it's getting choked off. So it's really important to make sure that it's as smooth as possible. And again, shrinkers use 23 hours a day. Even when they're in the preparatory, it's a good idea to go ahead and put the shrinker on and use the shrinker when the prosthesis is not in use. And it is not to be used while wearing the prosthesis. So after we've moved past the initial kind of healing stages, and the patient's residual limb is ready for a prosthesis, we'll typically start with preparatory prosthesis. And that's typically simple, lightweight plastic and a simple components, simple knee, simple foot, something that's stable and easy to initiate that gait training with. And during this time, we're looking to start the rehabilitation process, get the patient used to weight bearing, get the patient used to how the residual limb feels inside the socket, and how they need to start learning to walk, right? And during this initial preparatory time, we're looking to kind of establish the balance, the targeting, the positioning of the residual limb in space, and starting to develop that proprioception as a prosthetic user to know what those sensations inside the socket are telling them about the prosthesis. And also during this, during this initial time of rehabilitation with the preparatory prosthesis, we're looking to see that residual limb mature. We're expecting a lot of volume fluctuation to occur during this time, but we would hope that volume fluctuation continues in a downward trend, meaning that they're continuing to lose volume as they're using this prosthesis, the preparatory prosthesis. During this initial use, we're going to work up to full-time use. It's not expected that patients will take their prosthesis home and immediately start using it and be able to even tolerate it all day. It's definitely discouraged. We have wear schedules that we provide every patient when they get a new prosthesis. And typically, we'll start with 30 minutes to an hour and kind of work up from there. But the goal, by the end of their time, they're coming out of the preparatory prosthesis, the goal and the hope is that they are able to work up to that full-time use and that functional independence, or at least, use it for quite a while, several hours at a time. The goal is certainly full-time use. So then once you move on to the definitive, right, this is typically fit later than 6 months. And, we're using definitive components. You still can adjust and accommodate for some volume change. But generally speaking, the amount of adjusting that we can do to a definitive is substantially less than that of a prep. All right, mobility levels, the infamous K levels that plague everyone. They are useful. They certainly are helpful. It kind of gives us a way of grouping patients into various functional levels. And it's based on their current or anticipated potential for ambulation with the prosthesis. It ranges from K0 to K4. At the K0 level, this patient is typically bed or wheelchair bound. they're not expected to be able to use a prosthesis, and the prosthesis will not enhance the quality of life in this case. So if someone is a K0 level ambulator, functional level 0, they won't be able to have a prosthesis. The K1 functional level is a bit broader. This is typically reserved as your household ambulator. They're typically not using the prosthesis out in the community as much. But this can range anywhere from using a prosthesis to stand and transfer. It can be as simple as that. I've had several patients that's all they use the prosthesis. That's fine. That's absolutely necessary to have a prosthesis to be safe during those times of standing and transfer. And then it can kind of range up to doing some limited walking inside the house. These patients typically use assistive devices, typically a walker. So functional level 2 or K2 is our limited community ambulator. These are the patients that we're expecting to use the prosthesis on a daily basis. They're using it to help them get around at home and some in the community. They're typically limited in the speed that they can walk, and they kind of the key terminology that we're using and the key terminology that our insurance companies that we deal with are using are variable cadence, variable speed ambulation. So sure, anyone can walk a little faster or a little slower, but we're really looking for that wider range, variable cadence, and their ability to traverse environmental barriers, right? This group might have a little bit more trouble with stairs and curbs, and will typically still require assistive device, potentially even when out in the community. Functional level 3, this kind of gets to your community ambulator. These, again, the key terminology here is ambulating over uneven terrain and at variable cadence, variable speed, right? They're able to walk fast, they're able to walk slow, and their typical day would demand that they do that. They're typically unlimited in their community ambulation. They're able to traverse stairs, hills, ramps. They can tackle any barrier that they might encounter during the day. And then the functional level 4, that's reserved for really high impact cases, child athletes, really active adults. All right, so moving on to designing of a transfemoral prosthesis. The first thing we're going to talk about is the socket design. Typically, I'm going to go in a little bit different direction than probably most of you have seen before. Typically, you'll see this kind of the two major socket designs as ischial containment and quad, right? Those are kind of the typical old school terms. They've been around for a long time. But really, anymore, and we'll get into this in a little bit, you have ischial containment where you're actually containing that ischium or the ramus or both. You're achieving a bony lock within the prosthesis. You'll have a narrow ML shape, typically triangular. And the whole idea behind ischial containment is to control that abduction that occurs during mid-stance when the femur wants to abduct. And then you have subischial. And I would classify the quad socket as subischial. We're not containing the ischium. The socket is below the ischium. It may be, the ischium may be resting on the socket. It may be supported by the socket, but it is not contained within the socket. And that's a key difference. And we'll get into a bit more specific. So kind of a quick review about the quad socket. The ischium is pushed onto the posterior shelf by the high anterior wall. We're kind of pushing them back onto that seat and keeping the weight-bearing forces on that posterior shelf. It's a very square shape. It's very typically pretty easy to distinguish a quad socket. They're very square when you look at them, top down. Typically, these sockets are fit with a Skinfit Suction. and they pull themselves into the residual. They pull the residual limb into the socket through a hole in the end. I'll show you a picture of that later. They're pulled in that way. It can be used with other forms of suspension and interface as well. So ischial containment, and again, that's that bony lock of dropping, of containing the ischium and or ramus within the socket. These trim lines are higher. The goal of the ischial containment is to increase that femoral adduction. The socket also comes up higher over the trochanter to help force that adduction as well. And then the medial lateral dimension of the socket is narrowed to help provide that distal lateral force to adduct the femur. So you can also end up, you can have an ischial containment style socket, but if it's not containing the ischium, you can lead to more proximal medial pressure when this happens. And then it kind of ends up being kind of like that quad socket where when the femur wants to abduct, you have a distal lateral force and a proximal medial force trying to cancel that out. So then you'll typically get some increased gapping at the proximal end as well. So if typically speaking, the ischial containment socket is most places the standard of care. So then why even discuss removing the brim? Why discuss this sub-ischial level? The quad socket has known to have difficulty keeping a femur adducted. And there was quite a large VA study where they had patients standing with their quad sockets and they took x-rays of them. And almost all patients had excessive abduction. And that's kind of what drove the development of the ischial containment socket. But when we're talking about designing an interface for someone, we want them to be comfortable. We want them to wear it. Sometimes those ischial containment sockets can be uncomfortable. Some patients don't tolerate that pressure very well. Right, so we want to improve the range of motion. The ischial containment sockets come quite high onto the residual limb. We want increased flexibility and then comfort and ease of donning. But with all this, you still have to maintain socket stability, right? We don't want to provide someone with a pair of bedroom slippers just because they want to be comfortable. They're comfortable, but they don't provide any support. They don't do anything for you. So you don't want to go too far in the direction of, oh, let's just make everything comfortable. We want our patients to be able to have a stable residual limb, but at the same time, sometimes when you go to that maximum stability, those ischial containment sockets, that can be too much sometimes for patients, right? So you want to try to strike a balance of, you want that tennis shoe. You want something that's nice and supportive, that controls positioning, but isn't just, loosey-goosey, sloppy fit that's all over the place. You need to maintain that stability so that they can properly control and load the prosthesis. So when we're talking about I'm going to touch on two sub-ischial designs here really quick. The first one is a high fidelity interface design, and it uses areas of alternating compression and release to have targeted compression on the residual limb. So we're not just circumferentially squeezing, we're actually pressing in specific areas and then allowing those open windows, or it's not always open windows, but we allow areas for that tissue to flow. So when we're talking about these panels these areas of pressure, the compression areas are perpendicular to the surface of the long axis and the surface of the residual limb. They're diametrically opposed from each other. They're orthogonal to the limb and they're parallel to the limb axis. We're trying to, the idea is you have the femur inside of a sac of fluid, right? You have a femur in there and you're trying to stabilize the femur. That's what every socket design is trying to do. So in the idea of HiFi, you're pushing some of that fluid, some of that tissue out of the way, and you're getting part of the socket closer to the femur. And then you're squeezing in oppositional forces. So you're really solidifying the limb and you're getting that area of compression closer to the residual limb. And then so the idea is, you get better stabilization of the femur, then you don't need as much containment at the proximal end. Sometimes these sockets still are ischial containment. You can use HiFi, whether it's ischial containment or subischial, but it's something that we use, and you're probably more apt to see a HiFi socket than you are a quad, would be my guess. Quads are not used very much anymore. Another type of subischial design that we use is Northwestern University flexible subischial vacuum, or new Flexiv Socket. Vacuum is an integral part of this socket design, but essentially it allows for lower proximal trim lines, particularly the hard socket can be lowered. The proximal several inches to maybe the proximal third of the socket can be flexible. And then a seal is achieved externally with the sleeve. So the theory behind the new Flexiv Socket is we're really compressing that residual limb. Again, this is a common theme. If you look more and more into even some of the early research as they started looking into, how much of this ischial containment is needed. One thing that they found is anytime you don't have ischial containment, you need more compression. You have to stabilize the tissue somehow. So in the case of the new Flexiv, we're using a really, really stiff liner that's undersized to the patient to really compress the tissue. It kind of creates that barrel shape that you see there. And then we place the limb in a socket that's been aggressively modified, particularly at the proximal end, to accentuate that shape distortion and to lock the patient's limb in. And then we use vacuum with the new Flexiv socket as well, to help really increase the coupling between the socket and the residual limb. So when we're talking socket design, it's kind of, the question is, who is a good subischial candidate? It's really hard to nail down. The literature doesn't say much specifically. As you get a shorter residual limb, it kind of goes back to those initial principles that we talked about, right? As you move up the residual limb, you're losing that adductor strength. You're decreasing the stability. So shorter residual limbs certainly benefit more from that ischial containment to really lock everything into place and provide as much support as possible. So short residual limbs don't really work with subischial sockets. Roughly 5 inches. Any shorter than that is really tough. And then really, really soft limbs or limbs that do not have myodesis, myoplasty, it's really tough to stabilize everything. So typically good candidates for subischial sockets are, they'll have a longer limb, firm musculature with good stability of the musculature in the limb. That's not to say geriatric patients don't do well. They actually can do very well. But it goes back to the question of, you're trying to figure out a way to stabilize the residual limb within the socket. And there's different approaches that we can use. And we have a completely separate presentation that goes into much more detail on the ins and outs of transfemoral socket design. So options for suspension for a transfemoral prosthesis. You can have sleeve suspension, right? The liner can be reflected over the top edge of the brim, and then a sleeve can be rolled up. This really only works in subischial designs, but it is out there. The more common version of suction suspension for a transfemoral prosthesis is that internal sealing ring. So that the ring is pressed against the edges of the socket, air is expelled distally, and then not allowed to re-enter the system. So you achieve your seal internally. That's the most common form of suction. You can also add a vacuum pump to that as well, and then you have vacuum to either one of these sealing. And then Skinfit Suction, right? Skinfit Suction implies that there is not a liner used. And then the residual limb is pulled and typically kind of elongated as you pull into the prosthesis. That's assisted by some kind of either a ACE wrap or a donning bag, and it helps to pull the residual limb into the socket, and then they're fit directly against the socket, and it's sealed at the distal end. Of course, there are locking options for transfemoral prostheses. Pin can be used. I don't use pin very often. It's really hard to line up the pin on the end of the locking liner with the distal pin receiver in the socket within the locking mechanism. That can be difficult to line up. And it also, as you can see in this picture, this patient has a flexion contracture, but if you don't have a flexion contracture, then a pin really doesn't work because it elongates the limb. It adds quite a bit of bulk to the end of the residual limb, which then, a lot of times that can interfere with placement of the knee center. So you might see pin locking mechanisms for transfemoral, but not very often, and they can be really tough. For locking mechanisms, probably what's more common is a lanyard mechanism. Sometimes we'll add a second attachment at the proximal end of the socket. So there you have two straps that are fed through the socket at two different holes, and then they're secured with a Velcro and a D-ring to kind of lock the patient in at two different areas. Lanyard's certainly easier to don than pin because, right, you're fishing that lanyard through the end of the socket before you put it on. So it lines up itself. And then there's also proximal lateral locking mechanisms. And these are typically used when we're really worried about that build height, that length from the bottom of the residual limb to the knee. If they have a long residual limb, you have to minimize the distance between the end of the limb and the top of the knee. So sometimes we'll move that locking mechanism proximally and laterally with a lateral locking mechanism. So moving on, we'll discuss the components. You typically still have the pylons and the adapters that you'd see in a transfemoral or transtibial prosthesis. With the exception of rotators are more commonly used for the transfemoral level. And that's the upper right-hand corner picture. And so that device, you press a button and you kind of see it back here. It's right in between the socket and the top of the knee. So you press that button, and the distal end of the prosthesis is able to swing around. And this is really helpful for donning shoes, getting in and out of vehicles, tight spaces, things like that. It allows the prosthesis, the distal section of the prosthesis, to be moved out of the way. And then it only has one locking position. So once it returns to that neutral position, it will automatically lock. All right, so discussing knee joints. Again, the same kind of principles apply. Our choice of prosthetic components is limited by the functional levels. If someone's assigned a functional level 2, we're not expecting them to progress to K3, that does limit the amount of knees that we can use. And then again, kind of as you move up, you get access to more dynamic components. So you have to think about it as in, the lower functional level patients, we're talking single speed. And then as you move up to requiring more dynamic response, more controlled stance flexion, then you're moving into higher functional knees and variable cadence. So two things that we need a prosthetic knee joint to do. It needs to provide control, right? It needs to control the swing phase of gait and the stance phase of gait. And typically knees will be constructed in one of two different ways. We'll have a single axis of rotation, or polycentric, where there's multiple axes of rotation. For a knee joint, we're looking for it to provide, right, during that swing phase, we want smooth and controlled swing phase. We want it to control how quickly the distal segments advance during swing phase, and we need it to provide stability during stance phase and allow for comfortable sitting. So when we're looking at a knee joint, we have to look at goals of the patient. What are we wanting to do with this particular patient? How much stability do they need, or do they need something that's less stable and more dynamic? You kind of have this spectrum. On one end, you have knees that are very, very stable, and on the other end, you kind of have knees that are very dynamic and unstable. That's not to mean that they're unsafe. They're less. We'll get into knee stability here in just a second. But another thing we have to just consider is the overall weight of the knee unit. Transfemoral prostheses are heavier, and a lot of that weight does come directly from the knee, especially when you get into talking, fluid controlled knees, hydraulic knees. A lot of that weight is coming from fluid in the knee. And we also have to consider, how will we be able to cosmetically finish this knee if they so decide. So another thing that we have to consider when we're choosing a knee and how we're going to set that knee up is the length of the femur. So as you have a shorter residual limb, you need to have increased stability provided by the prosthetic knee joint. So that can be by selecting a more stable knee, or it can also be changed by sometimes how you set the knee up. And one of the things we can do is we can influence the stability of a knee by how we change the alignment and where the weight line falls through the knee. So if they're on the left-hand side, right, you have the weight line passing anterior to the knee joint. The middle picture, there you have the weight line passing through the knee joint, and then on a longer residual limb, sometimes the weight line will actually pass just posterior to the knee joint. So on the left-hand side, the knee is going to inherently be more stable. On the right-hand side, it's going to be less stable, but it gives the user more control in how the limb is going to function. So there are many options for knee designs when we're talking transfemoral level. There's quite a range from mechanical, kind of the functional level 1 and 2. You're looking at mechanical passive prostheses, and then once you move into K3 and K4, then you're starting to look at fluid control, and then you have microprocessor controlled as well, which is also mostly for the K3, K4 population. There are starting to be some exceptions to that, and some microprocessor knees that are designed to better function in the lower K3, higher K2 level and help patients make that transition. But that's still very difficult, and it really depends on the patient's insurance whether or not that can even be provided. But on the lower end, you actually have the really simple mechanical knees. They're typically can have a manual lock. They will typically have an extension assist mechanism and weight activated stance control, which means once the prosthesis is weighted to a certain amount, the knee locks. It won't bend in flexion. So then you have polycentric knees, and again, these are knees that have more than one axis of rotation. So that would be the knee on the upper right-hand corner. That's a polycentric knee. And there are many different designs of this. But one of the benefits of the polycentric is that it actually moves the center of rotation proximal and posterior to the knee axis, which moving the point of rotation makes it more posterior, makes the knee more stable. So then when you move to the mechanical and fluid controlled knees, you have both swing phase control and stance phase control that is able to better accommodate a wider range of gait speeds. Then when you get to microprocessor, you have more advanced stumble recovery. It can sense changes in terrain and moments acting on the knee. And they are fluid controlled microprocessor knees. All right, moving on to the foot. And again, you still kind of have the same types of things to consider when selecting a foot, right? You have that spectrum of foot design. What are we wanting? Are we wanting mobility and energy return, or are we wanting that stability and security? Another thing that gets thrown in with transfemoral amputation is, right, the behavior of the foot has a little bit more influence at what happens at the knee. So sometimes in transfemoral design, it's going to be more common to see feet that have articulated ankles that allow for that controlled plantar flexion. So as you have a foot that is able to having quicker plantar flexion, that helps to increase stability at the knee during initial stance loading response. That helps ensure that the knee doesn't buckle. Whereas if you have a really firm heel, that tends to induce a flexion moment, or can influence induce a flexion moment at the knee, which then the patient would either have to voluntarily control with the residual limb, or the knee could buckle, depending on the design. So there are certainly more things to consider when choosing a foot, but at the end of the day, it does kind of get back to that same basic concept of, what are the patient's goals for mobility? What do they need? Do they need something safe, secure, and stable, or do they need something more dynamic? And that kind of brings us to the end. So once you've got your socket, your interface, your knee, your endoskeletal components, and your foot, you've got a prosthesis. Looks like we have about 10 minutes left for any questions and answers. Feel free to unmute yourself and fire away.
I have a quick question.
Go ahead.
So for the hi-fi sockets, I was wondering, do you get typically any kind of resistance from insurance companies for coverage of those types of sockets? And if you do, what kind of documentation should the providers have in order to kind of get that covered more easily?
Yeah, that's a great question. Sometimes it really depends on the insurance provider. It's not always an issue. Sometimes it's something that we can get covered. Sometimes it's not. But typically, as far as documentation is concerned, we need to document that the current issue. If they have an existing prosthesis, it's really important to document the problems with the existing prosthesis and the existing fit, right? That's probably the biggest thing, is to document what isn't working. I guess if they've never had a prosthesis before, subischial sockets are not typically used on brand new patients. It's possible, but that's less common. So yeah, documenting what's not working is probably the best thing. And then, with the hi-fi in particular, the goal is to provide that increased stabilization of the residual limb. So documenting that we're expecting increased function by providing a more stable socket with lower trim lines.
If I can help or put in, so it really comes down to sum of all the parts. They look at what is the patient, basically where's the patient functioning at? How are they functioning before, and what is their goals now? And it takes everything from the input from basically that multidisciplinary team approach between the physician, prosthetist, and physical therapy, or occupational therapy. Let's say if we're talking about an upper extremity, there'd be your certified hand therapist. But it's where are they at? Will this prosthesis help them function at a higher level? Is the patient motivated? And it's kind of all that comes together. It's all brought together, but it really goes to the physician's note for justification for the components, and it depends upon the insurance. I do know just recently, like Dr. Gonzalez called, talk, and the thing was the person who was denying really didn't have much true knowledge. And it was kind of like, it really took the physician making that call to gently educate them on why it's necessary or indicated.
Got it. Thank you. I guess the reason I was asking is I was hoping to get some words of wisdom of how do we prevent getting to like a peer-to-peer, like just so that our documentation is like perfect and they just approve it from the get-go. But I guess that's in an ideal world.
Actually, I think it comes down to your wording on it. And actually the peer-to-peer actually ends up being beneficial, because when it's peer-to-peer, that person will understand what you're talking about, not necessarily at the lower levels.
That's a good point. Thank you.
Yeah, I think I misunderstood your question there. Thanks for clarifying that, Ed. It really does go back to that multidisciplinary approach, right? It typically doesn't work well if we're just the only ones saying it. So we certainly do need, that function to be backed up in physician's notes, and it's also helpful to have that in PT notes from time to time as well, for sure.
Any more questions?
I had another quick question. So I work mostly with pediatric patients, and I was wondering how that and specifically growth impacts your design choices, and what you recommend.
It cut out just a little bit there. I didn't quite get the full question. Can you repeat that?
Oh, I'm sorry. Can you hear me now?
Yes. Yep.
Okay, so I said for pediatric patients, how does the growth considerations, how does that affect your design choice and what you recommend?
Gotcha. Okay. A lot of the growth considerations, that's dealing with the length of the prosthesis. As patients grow, they also do have, they grow circumferentially and lengthwise in the limb, as well as height, right? Distance from the pelvis to the floor. Pelvis to floor, that's easy. We have those alignable components, we can pull the tubes apart, provide different components as the patients are growing. So that's easy. Accommodating the limb growth, that's a little bit more difficult. Sometimes there's things we can do to the socket to adjust and account for changes in the limb as they happen. But at some point, we're discussing replacing the socket or replacing the other components. And then the other thing is, as the patient gets heavier, they'll need different components as well. So everything is weight rated, particularly the feet. So, if a foot is designed to operate from, 50 to 75 pounds, once they're over 75 pounds, the foot's not going to operate properly. It's going to deflect too much. So then we also kind of need to keep track of that and then bump them up in category of components as well. So there's a height component, there's a weight component. And then, there's a time typically when most patients are no longer, they need to move to those adult components for safety and weight rating.
With pediatrics, it's kind of like life. The only constant is change. So they're going to go through multiple prostheses along the way. It's much easier when they're younger. After they hit 21, there's a lot, I think, more resources available when they're pediatric. Once they hit 21, it starts getting a little more challenging. But anyway, any other questions?
I have a question. Hi, Jeremy. I'm curious about the adults who are K3, K4, who may have their rehab prosthesis, and they may have like one more that is, much more better suited for them for how they have progressed and healed and evolved. But and it's kind of feeds off of what Ed was just saying. how frequent or common is it or easy is it for someone to be able to acquire something so that they can go to another level of either some kind of sports activity or just to have another choice in a limb to, maybe be able to do something a little more dynamic. Maybe it's just they have another foot they can pop on that gives them a little more flexibility, but then they take it off for just everyday use for just going to work or something. Can you reflect upon that? What's common?
It's pretty difficult to get in adults. This is certainly easier for children, but in adults, it's more difficult to get coverage for multiple prostheses. It's pretty rare. So, right, when we'll sometimes try to make the preparatory as kind of like, they get in a sticky situation, maybe they can use their preparatory or their previous prosthesis a little bit, while we're repairing the new device. But really what we have to try to do is design the prosthesis so that, especially in the K3, K4 level, they're doing everything from normal walking around the house to, doing some exercise and walking longer distances, more barriers. So we really try to have something that will work for them in all of those cases. It gets tougher when you're talking about just trying to get a activity specific prosthesis for the adults. That's a little harder to do.
If I can add, one thing on one of the realities is it's going to come down to your payer source and the reason why. For some, like a workman's comp situation versus you have some people who have lots of resources, and it depends on the particular insurance. And I think the situation when you're talking K3, K4, you may be looking at, here's someone who whether talking about adults, maybe one guy comes to mind. He's an electrician, right? But he's also a hiker and a camper. And so he's got one type of prosthesis he wears when he's work, and a different one when he's out doing real rugged terrain. So it comes down to the payer source there and where their functioning level is and what their activities are. As usually, and Jeremy, please correct me if I'm wrong, you're looking at a replacement of a prosthesis or at least a socket. And it depends on the components, but like 3 to 5 years. Is that about right, Jeremy?
Yeah, I would say replacement sockets are probably more common between the 2 to 3 year mark. They can certainly happen before then, especially more during the first couple of years after the amputation, right? We want to see most of those changes happen during the preparatory, but the reality is the residual limb is going to continue to change for at least the first 2 years. So it's not uncommon to do another socket replacement that first year, but then after that, yeah, typically 2 to 3 years, and then a prosthesis is expected to last about 5 years as far as the rest of the components.
And then they may have different components. If someone's a runner, so then they're going to have more of a blade for when they're running, but then have more of a normal polycentric foot if they were someone like a 3-4. Is that about right, Jeremy?
Yeah, I mean,
Well,
it could. I mean, blades for running, they're definitely, that's all they're good for, right? Whether we're talking transtibial, transfemoral, if someone's using a running blade, like a true running blade, that's all they're good for. You wouldn't use that in walking. So, if you do have a payer source that will cover that, if we have 2 specific activities that we're trying to get, if we can prove that, they need a prosthesis for this, their daily activities, and then they need a different prosthesis for this different environment. If we have the right payer source, we can get those approved. So yeah, you might have an activity specific prosthesis that's set up for running. That prosthesis is going to function very poorly as a walking everyday limb. It's going to be unstable. It's going to be just really bouncy. It's actually going to be too tall for like walking loads. So you can have justification to change between 2 different types of systems if you have the right payer source. But if we don't, right, if the payer source is only limiting, they're only going to pay for one device, then we have to try to design that prosthesis to cover as much of that realm as possible. And then make repairs and changes when it doesn't.
Any more questions, anybody? If not, we're going to go ahead and wrap it up. Thank you for participating. Was really glad to see so many residents involved and clinicians. We have coming up in the near future from the transtibial and the PT treatment component, and then the same for transfemoral and the treatment component. And hopefully you've registered to be part of the Limb Loss Restoration Symposium, which is on April 27th, 8:15 to 12:30. Here we have the top docs and clinicians presenting. It should be really, really interesting. And we're kind of taking the journey of somebody who's pre-surgery to the component that have their prostheses and have returned it back to a hopefully full life. Again, thank you all for participating. You will be receiving something just so we'd like to get feedback on what you thought of the presentation by Jeremy. And thank you very much, Jeremy. And thank Meyer for sponsoring this.
Yeah, glad to be a part of it. Thank you all for coming.
Bye. You all have a good day.